So now let's talk about the parenteral agents. So these are still general anesthetic agents, but they are given parenterally. Okay, the first and the most common is propofol. It's the most commonly used parenteral agent or parenteral anesthetic. So it is highly lipophilic, so it is able to enter the brain and the spinal cord and accumulate in fatty tissues. So propofol should be administered within 4 hours of removal from packaging. This is because it causes lipid emulsion formation. And if you give this after 4 hours of removal from packaging, it causes significant pain on injection and it causes hyperlipidemia. Propofol is often used for induction and maintenance of anesthesia as an alternative to inhaled anesthetics. The adult induction dose is 1 to 2.5 milligrams per kilogram, and the dosage should be decreased in the elderly due to reduced clearance. And it also should be increased in young children, or if you give it to young children, because of rapid clearance. Aside from being used for induction of anesthesia, propofol is also used for sedation. So for a sedating dose, you usually give around 20 to 50% of the general anesthetic dose. So the presumed mechanism of action of propofol is through the potentiation of the chloride current mediated through the GABA-A receptor complex. Propofol is a potent respiratory depressant and it can cause apnea if you give more than what is needed. Propofol also has antiemetic properties, so this can also be given to prevent or to treat vomiting. Did you know that propofol is also called milk of magnesia? So it looks like milk, and also this is also the drug known to have been given to Michael Jackson before he succumbed. They say it was an overdose of propofol. So maybe he was being given propofol shots because he was known to have insomnia. So because this is a sedative, that's why he was given propofol. We also have thiopental and methohexital. So these are the barbiturates or the hypnotics. So they have been largely replaced by propofol as induction agents. This is because also barbiturates are likely to be abused. So it has effects on inhibitory transmission, probably from activation of the GABA-A receptor complex also. Effects on excitatory transmission are less well understood. So these barbiturates produce dose-dependent CNS depression ranging from sedation to general anesthesia when administered as bolus injections. They do not produce analgesia. Instead, some evidence even suggests that they reduce the pain threshold, causing hyperalgesia. Now, thiopental sounds familiar, doesn't it? I'm sure you heard of this drug before. Thiopental is known to have been used before during interrogations, specifically torture interrogations, which makes sense because it causes hyperalgesia. And as a hypnotic, it also seems to get the truth out of the one being tortured, thus the name truth serum. Although there are also other drugs called truth serum, thiopental is one of them. So these drugs are useful in management of patients with space-occupying intracranial lesions because of its ability to decrease intracranial pressure and cerebral metabolic rate. So it may provide neuroprotection from focal cerebral ischemia, such as stroke, surgical retraction, or temporary clips during aneurysm surgery. But it cannot protect against global cerebral ischemia, for example, that one caused by cardiac arrest. Barbiturates are respiratory depressants, so they may produce transient apnea. Also, it's important to take note that mixing barbiturates with drugs in acidic solutions during anesthetic induction can result in precipitation of the barbiturate. So that's why you should not give barbiturates with other drugs in the same IV tubing. So ideally, you should give barbiturates in a different IV tubing or intravenous tubing. Or if you only can do one, or if you can only use one IV, so you have to make sure that the barbiturate has cleared the IV tubing before giving other drugs. Compared to propofol, barbiturates produce a higher incidence of wheezing in asthmatics. So this is another thing you have to consider, or this should be avoided in asthmatic patients. This is attributed to histamine release from mast cells during induction of anesthesia. Okay, so we also have etomidate. So etomidate is a hypnotic, but it is not an analgesic. So it is chosen for its minimal hemodynamic effects. So it does not cause instability of the cardiovascular system. It has minimal changes on the heart rate and the cardiac output. So that's why it is preferred for patients at risk of hypotension or patients at risk of MI. So etomidate appears to have GABA-like effects and seem to act primarily through potentiation of GABA-A mediated chloride current also, just like the previous anesthetics or the previous IV anesthetics we discussed. So etomidate has no neuroprotective properties. In fact, it increases EEG activity and it is associated with seizures. So this is an anesthetic to avoid in patients who have seizure disorders. Its use is also limited due to the endocrine effects. So it actually causes adrenocortical suppression by the inhibition of 11-beta hydroxylase. No? So if you remember, this is an enzyme that is necessary for the conversion of cholesterol to cortisol. So this adrenocortical suppression lasts for 4 to 8 hours after the induction dose. Etomidate is an alternative to propofol and barbiturates in patients with compromised myocardial contractility. Again, it does not produce analgesia, and post-op nausea and vomiting are common. Ketamine is useful for anesthetizing patients at risk for hypotension and bronchospasm. So the major effect is probably produced through the inhibition of the NMDA receptor complex. Ketamine, however, produces dissociative anesthesia. So this is a characteristic state observed after an induction dose where the patient's eyes remain open with a slow nystagmic gaze. So this is what we call the dissociative anesthesia. It is a cataleptic state. So the patients have profound analgesia. They are unresponsive to commands. They have amnesia, but their eyes are open. They can also move their limbs involuntarily, and they breathe spontaneously. Another downside of ketamine is that upon emergence from the anesthesia, patients experience emergence delirium, which is characterized by hallucinations, vivid dreams, delusions, out-of-body experiences, and increased and distorted visual, tactile, and auditory sensitivity. So that's why it causes serious patient dissatisfaction and it can complicate post-operative management. So that's why it's not a very nice drug to use. So ketamine also produces transient but significant increases in systemic blood pressure. So you do not want to use this in patients who have cardiovascular problems. So it can also increase heart rate and the cardiac output, maybe because of centrally mediated sympathetic stimulation. So the upside of ketamine, though, is that it can be administered by multiple routes. So it can be given IV or IM or oral, rectal, or epidural. So that's why it is a useful option for pre-medication in patients who are mentally challenged or patients who are uncooperative.